Hi, I'm Ivor Benjamin, President of the American Heart Association, and on my right is Dr. Bob Harrington, President-elect of the American Heart Association, and on my immediate left is Dr. John Warner, immediate past President of the American Heart Association. We are here at ESC 2018, and this is AHA Science News. Today we will review 4 trials that were presented here today, and I will begin with the first, that is entitled Efficacy and Safety of Tafamidis in Transthyretin Amyloid Cardiomyopathy, the ATTR-ACT trial. So transthyretin amyloid cardiomyopathy is a fatal and rare disease for which there are very few treatment options. This study set out to test the role of a novel drug called tafamidis. And the way this drug works is because amyloid results in deposition of amyloid fibrils in the heart, and that is associated with heart failure. Tafamidis actually stabilizes this drug so that the soluble form remains as a tetramer. And so they tested and enrolled over 440 patients in a randomized trial to test 2 doses compared with placebo. This was a positive trial because this drug not only reduced all-cause mortality, it reduced hospitalizations, and it was to show improvement in functional capacity measured by a 6-minute walk. It also included a questionnaire, the Kansas City Cardiomyopathy questionnaire that tested quality of life. So all in all, this represents an important advancement in the management of patients with transthyretin amyloid cardiomyopathy. All right, Bob, let me turn to you now to tell us about the Commander-HF trial.
Commander-HF is an interesting trial, Ivor, in that it sets out to try to understand the role of an anticoagulant, in this case, the factor 10 inhibitor, rivaroxaban, in the management of patients with heart failure, with reduced ejection fraction, and concomitant coronary artery disease. Now, what's the background for this? The background is that there is some evidence that low-dose rivaroxaban offers benefit to patients with coronary artery disease on top of standard antiplatelet therapy with aspirin. That's an important observation, and those results have been presented in the past. The background with heart failure is that some of heart failure is felt to be mediated through a coagulation and thrombosis mechanism. Some of the dysfunction of the left ventricle may be such, and it may be that that thrombosis-mediated issue also then causes inflammatory changes, which may also lead to susceptibility to plaque rupture and coronary artery disease. So there's a biological rationale here. There's some observational data with the vitamin K antagonists that suggested that anticoagulation may be beneficial in preventing ischemic events. So these investigators set out to do a large, more than 5,000 patient randomized clinical trial to test whether or not low-dose rivaroxaban in patients with heart failure without atrial fibrillation but with coronary disease might benefit. Disappointing results. This trial showed us that there was no benefit of rivaroxaban at this dose given to this group of patients compared to standard therapy. Of course, all these patients were on very good heart failure regimens. What did we learn here? We learned that there's no benefit of adding rivaroxaban to our patients with heart failure unless they have another indication for anticoagulant therapy. Number 2, we have not excluded that the higher doses of rivaroxaban might be beneficial. But maybe the most important thing we've learned about from this trial is this is still a very high-risk group of patients. At little over two-year follow-up, there was almost a mortality rate of 21%. So this is an extraordinarily high-risk group of patients that we need to do a better job. Commander showed us that rivaroxaban at this dose was not going to add incremental benefit.
Bob, thank you. John, can you tell us about MITRA?
So the MITRA.fr study was presented at ESC this year, and which is the next chapter in the MITRA-CLIP story. And so the MITRA-CLIP is a percutaneous edge-to-edge repair of for mitral regurgitation in patients who have what we call functional mitral regurgitation, meaning that the leaflets of the mitral valve are normal, the chordae are normal, but the ventricular geometry is altered and the ventricle is dilated, and you get mitral regurgitation. So this is the percutaneous repair of that with what's called the mitral clip. So this was an important trial, 452 patients, all of whom had heart failure and severe mitral regurgitation. The ejection fractions were between 15 and 40%. So these are people with abnormal ventricular function randomized to the MITRA-CLIP or to medical therapy. The procedural success in this was very, very good. So 96% of the patients that had the MITRA-CLIP placed had a successful procedural result. And it was very, very effective, as it has been in the registries, in actually reducing the amount of mitral regurgitation. So more than 95% of the patients that received the MITRA-CLIP had a reduction by 1 grade of their mitral regurgitation. And more than 90% at the end of the procedure had 2+ MR or better. So the procedure itself did what it was supposed to do. It reduced mitral regurgitation with a very high procedural success rate. The disappointing thing was, and the endpoint, by the way, on this trial was the 1 year measurement of death or an unplanned hospitalization for heart failure. So unfortunately, this did not show a benefit for the MITRA-CLIP. So right around just north of 50% or so in patients who received the MITRA-CLIP versus just medical therapy had that endpoint, meaning they either died or had an unplanned heart failure admission. And unfortunately, the mortalities were similar but high in showing the morbidity of this disease. The mortality in the MITRA-CLIP group was 24%, 22% in the medical therapy group. So again, this is a morbid problem, a difficult problem, but it doesn't look like, for now, in this patient population, that the MITRA-CLIP had the desired results that we all hoped we would see with this repair. So more to learn. It's a very interesting result. There will be some subgroup analysis of the patients who did appear to derive a benefit, but for now, it's not something that can routinely be recommended in patients with functional mitral regurgitation and a reduced ejection fraction with symptomatic heart failure.
Still more to be done.
More to be done.
Well, I'm going to look back to you and let's talk a little bit about the Global Leaders trial.
Yeah, Global Leaders, interesting trial presented earlier today by Patrick Sorois from the Netherlands. Global Leaders is addressing what I would call one of the biggest conundrums in interventional cardiology with regard to antithrombotic therapy, and that is, what do you do after the stent goes in with regard to antiplatelet therapy, various combinations of antiplatelet therapy, and duration of antiplatelet therapy? That's the conundrum. And what this group of investigators set out to do was to ask the question if a modified monotherapy regimen could be compared with a standard dual antiplatelet regimen over 1 year and then subsequently at the primary endpoint of 2 years, could you get ischemic benefit with less bleeding? And that's always been the balance in interventional cardiology with regard to antiplatelet therapy. So the two arms here, the reference arm and the control arm, was standard dual antiplatelet therapy in patients with stenting. Aspirin at a low dose, and then either ticagrelor or clopidogrel. Ticagrelor given to those patients with an acute coronary syndrome, clopidogrel given those patients who had stable presentation when they had their coronary intervention. The experimental arm was aspirin for 1 month, followed by ticagrelor for 23 months. What was interesting in the control group is that they made a second shift. At a year, they dropped the ADP inhibitor and just kept aspirin. So from 0 to 1 year, you're comparing ticagrelor with a month of aspirin to standard dual antiplatelet therapy. After 1 year, you're comparing ticagrelor monotherapy to aspirin monotherapy. Primary endpoint was at 2 years, but they had very pre-specified endpoint analysis at 1 year. What did we learn? Well, first, let's look at the primary endpoint, which is always the fair thing to do in a clinical trial. Primary endpoint was the composite of death or Q-wave myocardial infarction. No difference statistically between the two arms at 2 years, although the trends with a p-value at 0.07 favored the experimental arm. An interesting observation, more patients remained adherent to the aspirin-only arm than they did to the ticagrelor-only arm, and whether or not that influences the result is something that the investigators feel that they need to do further work on to understand. The interesting analysis in this was that at 1 year, you do see a benefit of ticagrelor with only 1 month of aspirin therapy relative to the dual antiplatelet strategy. It's not the primary endpoint. You have to view it with some, maybe a little bit of caution. But I think what this enters us into, Ivor, is this notion that we can more and more perhaps personalize our choices of antithrombotic therapy. We're now starting to think about longer, more intense durations for patients who have complex disease. Perhaps these data add to that story where we can personalize for a year and rethink what we want to do beyond the year.
We've had a chance to hear about 4 different trials. They range in trials that are looking at what we will call proteinopathies. This is really where you've got mutations in a gene such as transpyrethrin, and we were actually able to identify a potential advance. Again, really being able to personalize the treatment of patients among a large number of patients with heart failure. And clearly, as you pointed out, in this particular case, in dual antiplatelet therapy, there may be an opportunity for us to be able to do that. John, in your case, we're now thinking about structural heart disease, where there continues, obviously, to be advances in that space. And, of course, it's the mitral valve and regurgitative lesions there where there's the biggest challenge compared with ours.
Yeah, I agree. And this is the MITRA.fr study was again shows that we're still learning, and what the procedure itself reduced MR, which is what it was designed to do, but that didn't lead to an improved outcome. And so I think we're still learning. Sort of it's more the ventricle than it is the MR in this case. And so I think the learning curve is pretty steep for all structural heart disease right now, particularly as we begin to look at higher and higher risk populations. So an important piece of data, again, just another chapter in treating mitral valve disease in patients with heart failure, which is still a significant problem. So a good piece of evidence to add to our understanding, and more to come.
Well, for Bob, John, and me, this is Ivor Benjamin signing off from AATR Science News. Thank you.